Can you all hear me now? He's going to have to stand here with the microphone next to me. Right, number one rule. We position the heart in attitudinally appropriate fashion. So this is the diaphragmatic surface. This is the right surface made by the right atrium, the left surface. And as Dr. Deshpande showed you yesterday, here is the anterior interventricular artery, and that is showing us how the morphologically right ventricle is forming the larger part of the anterior surface of the heart. So we have the left ventricle here that is forming the leftward margin as the heart moves up from its apex towards its base, and the short axis of the heart is at a significant angle relative to the long axis of the body. And as we pointed out yesterday, we just see a little bit of the left atrial appendage. There, beautifully you see it, and it's peeking around the left border here, adjacent to the pulmonary trunk. The pulmonary trunk, the pulmonary root, is anterior and leftward relative to the aortic root forming the centerpiece of the heart. Now, if we turn the heart and we sit it on its apex, this is how the anatomists in the past showed the heart. And it's only when the heart is in its attitudinal position that this is the posterior and descending artery. When we put it back into the heart and we look at the left anterior oblique projection, and we can zoom in now, we can now see the sternocostal surface of the heart, which is anterior. Clearly now we see that this inferior surface is diaphragmatic, and this is the middle cardiac vein, which is a correct designation of that structure, and running with the middle cardiac vein we have the inferior interventricular artery, and blockage of that inferior interventricular artery gives you inferior myocardial infarction. It is not posterior. This is the posterior surface of the heart, and it is this wall of the left ventricle that is closest to the spine, closest to the esophagus, that is the posterior part of the left ventricle. And those are the features we have to take into account when we're describing the conduction system. Now, I've turned the heart now so that you can see it in right anterior oblique orientation. I'm positioning it as far as I can in attitudinally appropriate fashion, and to do that, I put the superior caval vein directly on top of the inferior caval vein. And then you see, if I pass my probe into the inferior caval vein, I'll open the inferior caval vein, and I'll show you how the probe comes into the right atrium. You can just see its tip there. And this is how you might see it in the electrophysiological laboratory. And this is the point that Cossio made. As the catheter comes up the inferior caval vein, it is moving superiorly. If it was moving anteriorly, it would go that way. So it is a mistake for the electrophysiologist to think that this is anterior. In fact, this is superior, and we know that because there we see the superior caval vein. So the heart has been opened by an incision going from the inferior caval vein into the parietal wall of the right atrial appendage. In fact, it's opened the right atrial appendage also here in a cut across its margin adjacent to the right atrioventricular junction, and that's rather distorted the structure of the terminal groove. But if I put it back again as best I can, there is a groove here that runs down between the wall of the appendage and the wall of the systemic venous sinus. And if I flip back this wall of the right atrium, you see that inside the right atrium, in fact that's the mouth of the inferior caval vein, I have to come here to find the opening of the atrium itself. If I open that, in fact, I'm telling you lies there. I was showing you the left atrium. So excuse me for that. In fact, there now is the right atrium, and that looks much better. I apologize for that. I fooled myself there for a little moment. We can now very much better see the terminal groove. That explains why it looked funny. So now you see, as I open out the wall of the right atrial appendage and I turn it and I show it to you, there on its inner surface you see the pectinate muscles. And this is because the right atrial appendage forms the entirety of the anterior wall of the right atrium. Now, if you go to many of the textbooks, you will see that it is only this tip of the right atrial appendage that is described as being appendage. But then, when I hold the heart like this, and I show you the anterior wall of the right atrium, and this time, when I flip back the wall, you see that those pectinate muscles run all the way down from the superior caval vein to the inferior caval vein. They encircle the right atrioventricular junction. And now when we look at it from the inside, you see that they are taking their origin from this muscular bundle that runs round the anterior margin of the superior caval vein. I've put my probe there into the superior caval vein, and the muscle bundle runs all the way down towards the mouth of the inferior caval vein, and there is the mouth of the inferior caval vein. And this is the terminal crest, the crista terminalis. And the terminal crest on the inside marks the location of the terminal groove on the outside. And let me emphasize again that when we look at the diaphragmatic surface of the ventricular mass, there, running around the vestibule of the tricuspid valve, you see these pectinate muscles, and they're extending all the way to the opening of the coronary sinus. There is the opening of the coronary sinus, beautiful, guarded by the Thebesian valve. Guarding the opening of the inferior caval vein is the eustachian valve. And the eustachian valve, the Thebesian valve come together, and then, as I said, when I put a little bit of tension on the eustachian valve, there, springing into prominence, we see the tendon of Todaro. We can then see the hinge of the septal leaflet of the tricuspid valve, and that demarcates for us the triangle of Koch. Here is the coronary sinus at the base of the triangle of Koch, and the triangle of Koch is pointing with its apex upwards. And at the apex of the triangle of Koch, we have the atrioventricular component of the membranous septum, and that little dimple that you see there marks the atrioventricular component. If I lift it up, as I show you there, behind the septal leaflet of the tricuspid valve, and if I probe in there, that is the location of the interventricular component of the membranous septum. And there you see the medial papillary muscle supporting the leaflets, the anterosuperior leaflet, the septal leaflet of the tricuspid valve. And if I draw a line from the apex of the triangle of Koch to the medial papillary muscle, that shows us where we will find the atrioventricular conduction axis. So that's where we find the atrioventricular node. The bundle passes between the membranous septum, the crest of the ventricular septum. The right bundle branch then emerges here beneath the medial papillary muscle on the anterior limb of the septomarginal trabeculation. Now, I got sidetracked a little into showing you the triangle of Koch because it was there. I was going to start by showing you the location of the sinus node. So now I've come back to show you the superior caval vein, the crest of the right atrial appendage. And you see that there really is an acute top of the right atrial appendage. That is the crest. And you see there the terminal groove running down from the crest of the appendage. And in there, if you now look carefully, you can see that little yellow cigar-shaped area, and that is the sinus node. If I took a section across there, we would find the sinus node. It is inferior to the crest of the appendage in most instances. In 1/10 of the population, however, the node extends across the crest in horseshoe fashion. Now there's another problem, because there is a prominent artery that supplies the sinus node, and in 55% of individuals that artery arises here from the right coronary artery. In 45% it arises from the main stem of the left coronary artery. The artery then usually runs through the interatrial groove. I'm going to turn back the arterial trunks and I'm going to show you that interatrial groove. And this is the area of the interatrial groove. And now you're looking at it from the front. This is the superior caval vein. This is the crest of the atrial appendage. And the terminal crest, in fact, runs in front here and continues into the interatrial groove. And this area is another bundle of cardiomyocytes that are aligned with longitudinal conduction orientation, and this is Bachmann's bundle. And this is how the impulse reaches into the left atrium. So the artery to the sinus node, and that may well be the artery to the sinus node, although I can't be sure of that, comes up this interatrial groove, and then it can either pass into the sinus node from the front, or it can run behind the superior caval vein and enter the terminal groove from behind. In some instances, it forms a circle around the superior cavoatrial junction. And that is why, for the surgeon, the entirety of the cavoatrial junction should be considered a potential danger area. And if the surgeon opens the right atrium as Pradeep has opened this heart so as to gain entrance to the cavity of the right atrium, in 99% of cases, the surgeon would not damage the sinus node. I say, however, in 99%, because in a small proportion of cases, the nodal artery can cross the atrial appendage, or it can run behind and pass over the dome of the left atrium. But if that is the case, it will be visible as a prominent atrial artery. So that is the sinus node. I've shown you the atrioventricular node. I can also show you, as we look here, the location of the left coronary, the non-coronary sinus of the aortic root. And the front of the atrial septum here is where we find the retroaortic node. And when Yash and Shomo have been ablating arrhythmias from this non-coronary sinus, it's our belief that this is the tissue that they have been ablating. But we must finish our assessment by looking at the left ventricular outflow tract, because this is where we find the left bundle branch running down the ventricular septal surface to activate the myocardium. We've seen the right bundle branch already, and that was beneath the medial papillary muscle. Now, as we look at this heart, and I open it to you, and again I try to show you in attitudinally appropriate fashion, as it would be seen from left anterior oblique orientation. And let me orientate you as to what's going on. So there is the opening of the right coronary artery. This is the non-coronary sinus of the aortic root. And there you see the opening of the left coronary artery, the main stem of the left coronary artery from the left sinus. The left sinus has been transected, so there you see part of the left leaflet. And there is the hinge of the left leaflet from the parietal wall of the right ventricle. And that is interesting in itself. How much closer can we get? Can we zoom further in? Oh, that's beautiful. Because you see beautifully now that at the base of the left coronary sinus, there is myocardium. Here is the coronary artery. There is the leaflet. This is the sinusal wall. And so some arrhythmias can be ablated here from this myocardium. But it's also likely that the aortic ring that I showed you, that passes all around the aortic root, would be running through this little area of myocardium. So Yash, it is possible that when you were ablating from the left coronary sinus, you were ablating a remnant of that ring here at the summit of the left ventricular myocardium. But that myocardium fades out here because this is fibrous tissue. So there's no myocardium here that might produce abnormal rhythm. This is the left coronary sinus. There is the this is the non-coronary sinus. There is the interleaflet triangle between the non-coronary sinus, the left coronary sinus. But this is where we then find the conduction axis. Right coronary leaflet, right coronary sinus, non-coronary leaflet, non-coronary sinus. There is the interleaflet triangle that interposes between the two leaflets, and at the base of that we have the membranous septum. And you see that the membranous septum is continuous with the rightward margin of the area of fibrous continuity between the aortic valve, the mitral valve. This is what we call the right fibrous trigone. The right fibrous trigone, together with the membranous septum, produces the central fibrous body, and the conduction axis penetrates here through the atrioventricular component of the membranous septum. And you need faith to see the conduction system, but I think I can see the ramifications here of the left bundle branch. I can see some strands there that are beneath the endocardium that continue to that muscle bar. There's more coming into these muscle bars. I can see here the septal fascicle of the left bundle branch, and there I see the inferior fascicle that is running towards the inferoseptal papillary muscle of the mitral valve. The superior fascicles are running to the superolateral papillary muscle of the mitral valve. So I think I can see the location of the left bundle branch, and if you look very carefully, you see it coming here, taking its origin from the left bundle branch itself, and look how close that is to the right coronary leaflet of the aortic valve. If there is disease of this leaflet, and if you put a prosthesis in subvalvar position, for sure that prosthesis is going to lie on the left bundle branch. But when it comes back more posteriorly, the bundle of His itself is somewhat protected because that is running back and entering the central fibrous body. What we don't know as yet is the precise course of the axis itself that continues beyond the origin of the left bundle branch. That is the so-called dead-end tract, and we have to explore that because that then runs underneath the anterior part of this left coronary aortic leaflet arising from the left coronary sinus. And you see there is more myocardium there, and that could be generating arrhythmias. So there is much we still have to learn, but to me now, the most important part, when we describe all these findings, we need to do that in the setting of the heart scene as it lies within the chest. So I'll stop there and we'll move on to the next part of this morning's program.
Before we go to the next talk, are there any questions for Professor Anderson? the left fascicles